So today we have 5,685 cases, 79 deaths. We are currently working with 1,611 active cases and just shy of 4,000 recovered. Still working on a case fatality rate, 1.4%, which, as you've seen, has been dropping, been holding pretty steady there for a while. We anticipate that case fatality rate to land somewhere in the 0.6 to 1% range. Has been kind of the scientific anticipation of where that is headed. Currently, there are 121 either suspect or confirmed cases hospitalized between Sparrow and McLaren Hospital. 113 of those are confirmed, with 101 just in regular hospital beds, 12 in the ICU, and 12 ventilated. Total ED visits, emergency department visits in the previous calendar day, and this is from the 8th, because of when this data was put together, was 44. Last I calculated, Ingham County is about 40% of those hospitalizations, which is about where we were last week. So pretty much makes sense that being the most populous county that feeds into those health systems, that we would have a larger percent than other counties. I would expect that 40% would probably be, a fair random sampling of something that might, be fairly predictable moving forward. But we will keep tracking that as well on a weekly basis. So our hospitalization curve now since the beginning of the pandemic looks like this. So you can see we are looking at hospitalizations now that are far greater than what we saw in April. And that brings a lot of questions. People are like, oh my gosh, we have way more cases than we did back in April. We have way more hospitalizations back in April, and we were shut down. Why are we doing this? And why, lots of whys. One of the things I can tell you is that the context of this virus and what we're dealing with is very different now from when it was in April. So taking hospitalizations now, cases now, and all of the rest of that now, and looking at it with the lens of April is just not a very accurate way to look at it. So we have far more lower acuity patients in the hospital, far fewer severely ill. The treatment regime is very different. One of the things, though, that becomes very labor intensive, since most of these are not the seriously ill in the ICU, although that's a fairly significant number right now, is that they don't intubate patients early. They do steroids early. There's a number of, and they do the remdesivir. I always pronounce it wrong. I always want to say remdesivir, and I put the D in the wrong place. But a lot of that stuff happens first. And one of the other things they do is they prone patients. In other words, they put patients lying down, sort of tipped forward in order for the lungs to drain well. And maintaining patients, even on the hospital floor, with the need to prone them and those sorts of things, becomes labor intensive for the hospitals. So we still are concerned about hospital capacity and the ability to take care of these patients, because it becomes a very labor intensive thing to do. But we do have far lower acuity in patients that are hospitalized in general right now. So hospitalizations right now, starting in early August, when they changed the way that they had the reporting form, we can see that we have this trend with hospitalizations in ICU, and also the previous emergency department visits are this line down here, and then ventilated patients is this kind of bouncing up and down line up here. So currently, and again, remember, we switched to doing this as opposed to, hospitalized and at home, because it was a cumulative number. The number hospitalized now out of, 5,600 cases is not something that is really relevant. We need to be looking at how many are hospitalized relative to the number of active cases. So really what we're looking at right now is we've got 70.3% recovered. Our hospitalization numbers and our current active numbers, so we could figure out that percent. I don't have a graph for that. We're 28.3% of our cases since the beginning of the pandemic are active, with 1.4% deceased or fatality. So this is our curve that we've been trying to flatten, and we, got a little flat back in here, and then we got a little flat back in here, and then we had this big surge in cases in March that was largely attributed to a lot of MSU-related cases, because you can remember that steep curve right there paralleled a very steep curve in our MSU-related cases. The MSU-related cases have tapered off and have flattened out, whereas the community cases continue to go up. So I believe that what happened is we came out of that outbreak or that curve with MSU cases right as really a true second wave was starting to happen. And that's why you saw kind of the community level transmission take over after the MSU outbreak was over. While the MSU related cases certainly do impact the broader community, not to this kind of extent. This is not just about those cases impacting our broader community. We are in a stage right now of broad, widespread community transmission of this virus in our community and in most communities across this state and across the nation. So our incidence curve, daily incidence curve looks like this. Obviously, we're certainly at a point now where a rolling average is very helpful because, things are bouncing around quite a bit. When you look at these case numbers right here in the last few days, keep in mind that a lot of these people are people that we have not necessarily spoken to yet. And so these are referral dates. Once we get an onset date, they'll get backed into these days. So we did have this curve here. We're kind of, going back up, but it's really unclear where this incidence curve is heading until we know where these onset dates might land, because those bars do change as we get the cases attributed to onset date. Until we reach them, we use referral date. So percent positivity has now gone up into about the 6% range. 7% throws us into the B level risk on the MyStart map. So we're still in that A level. We're not low anymore, which is below 3%, but we still are in that 3 to 7% range, which is fairly low for positivity in the grand scheme of things. It certainly is higher than we would like to see. I did just check, I think Kent County and Grand Rapids is up at 11 point something percent. You see a number of counties around the state, 11, 12, 13%. So really, I would say that we're doing fairly well in Ingham County. Our case rate, our cases per million per day is lower than a number of the ones that I'm seeing, around the state, as is our positivity. So when we look at this and we kind of smooth these curves out with a rolling average, then you can see that this is, even though we had those big spikes over there and the up and down, this is, a nice, once again, upward trend in the number of cases. Again, even the rolling average is going to change as cases, especially when you're dealing with 100, 150, 200 cases in a day. We have to have time to reach those people and to get them put into onset dates. So the overwhelming number of cases literally across the board in this state and in this community is slowing a lot of things down. It is slowing down turnaround rates on lab testing. It is slowing down the amount of time it takes for, once that laboratory positive result comes out, it actually gets into the statewide system so that it's been reported to us. A lot of those things are lagging right now. So zip code wide, we are still with our highest level zip code at 48823 at 1971 to 1980. Things are kind of on the rise again in 48911. We're up to 761 to 770 there. I think we were more like in the 500s last week when we were looking at this. So we're starting to close that gap again now between 48823 and some of the other zip codes as we get past that major outbreak that happened that was MSU related and get into, broad community transmission across our community. And with widespread community transmission, you'd expect to see cases really follow some population demographics. Our most dense populations will have more cases than our more sparsely populated places. And then we will still have our outbreaks and our vulnerable population issues to deal with that might cause, numbers to go one way or the other in a particular zip code. So by rate, we see the highest rate in East Lansing as well, with the second highest in 48911. And then, other zip codes across the county, Okemos, Williamston, Weberville, not East Lansing, that's 48910 is what that is. Just the words East Lansing are in there for some reason. And then we go into Mason, Leslie, Stockbridge, and the Lansing zip code that's out towards the airport, as well as Hazlet. All of the rest have, really fewer cases than then really we're able to calculate a really accurate rate for. So that rate just sits down there in that very low range. So our heat map now still looks pretty much the same. We still have, more cases in 48823 than many of our other zip codes. But you're going to see, as that gap closes, this is going to start to fade, and some of these others are going to start to pop up, and we'll see, that heat map kind of shift a little bit as we move on. If we look in the 48823 zip code, I mean, you can already see that this yellow blob is starting to shrink just because of the relative perspective between it and the rest of the cases in the county. But we still do see these really tight circles here, 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 over here. And those are generally apartment complexes. So basically everyone in that apartment complex essentially has the same address, even though they might be apartment, B or C or whatever the apartment letters or numbers are. The street address is the same, and these get put in by street address. So you'll see those tight little concentric circles really in areas where we have apartment complexes. And there's a lot of student housing in these apartment complexes here in this Water's Edge area. This is Skyview over here. I think this is Campus View right here. Demographically, 50% of our cases are male, 50% female. We've been really holding in that 50-50 range for really quite a long time. I think if I had to recall, maybe most of the time of the entire pandemic, we've been really close to 50-50. It might shift a little bit, but not a lot. When we look at cases by age group, we still are seeing that 20 to 29 age group now drop as an overall representation of cases across the different age groups. Again, because we had that significant surge in the 18 to 24-year-old age group with that significant outbreak in MSU related cases. And now as community transmission broadly across the board is catching up, you're seeing cases in all age groups, which is starting to kind of, level those numbers out a bit. We still do see those two age groups, the 10 to 19 and the 20 to 29 as our highest ones. And again, if you dissect those out, what you will find is the 18 and 19-year-olds and the 20 to 24-year-olds make up the majority of both of those age groups by far. The cases are by race, 65% Caucasian, 13% African American, 5% Asian, 13% other, and 4% unknown. When we look at that by rate, we're at about 1,708 for our Caucasians and 2,271 for African Americans. So we do continue to see that disparity, that disproportionate impact on our people of color, particularly our Blacks and African Americans. In this case, we'll also look at Hispanics in the other one. We've pretty much evened out with our Asian population. Again, though, if we were to go even now probably and look at 48911, where we have a strong community that has come here from, many places around the world into Lansing, who's been a very welcoming community for many years, we probably would see that we have a disproportionate number of Asians in that particular zip code still that are impacted. This is a county-wide number, and so that gets diluted out a little bit. And there's really no reason to be dissecting the 48911 zip code at this point in time. Of course, we had to figure that out when those numbers were so high relative to all the others in the county. When we look at cases by ethnicity, they're 80.2% not Hispanic or Latino, 8.5% Hispanic or Latino, and 11.3% unknown. So our not Hispanic or Latino rate is 1,690, and our Hispanic or Latino rate is 2,094. So really kind of a similar disparity between Caucasians and African Americans and non-Hispanic and Latinos and Hispanics versus Hispanics and Latinos in these rates. When we look at our deaths by age, 2.5% 40 to 49, 6.3% 50 to 59, 15.2% 60 to 69, then 34.2% 70 to 79, and 41.8% over 80. So that's what 76% of our cases are over the age, or 70 or over. And that was quick math in my head. So if I got that wrong, anybody can correct me any second now. When we look at our deaths, we have been a little bit more not necessarily always 50-50 with deaths. So 53.2% of our deaths are male, 46.8% are female. When we look at deaths by race, 70.9% Caucasian, 24.1% African American, 3.8% other, 1.3% Asian. Again, we don't calculate a rate on that now, which is the best way to compare, because a rate calculated for anything under a number of, say, 20 is very unreliable in terms of a rate calculation. It's going to have a confidence interval that's going to be huge in terms of how confident are you in that number. What we do know, though, is that roughly 78% of our population is Caucasian, but 70.9% of our cases are Caucasian. Roughly 14 to 15% of our population countywide is African American, but 24.1% of our cases. You can't say it's X percent more or anything like that, because you have to calculate a rate in order to truly do a percent difference, or it's this many times more. But you can see that there is still that disproportionate impact even in deaths. So as soon as we hit a number where we can calculate rates, we will. I can tell you that I keep hoping we don't ever hit that number. We certainly will be able to calculate a Caucasian and an African American rate before we will be able to calculate a rate for Asians and others. So it could be at some point in time, we'll be able to calculate that rate for you. When we look at deaths by ethnicity, 89.9% are not Hispanic or Latino, 6.3% are Hispanic or Latino, and 3.8% are unknown. I believe our Hispanic population is in that range of 5 to 6%. Somebody can correct me if I'm wrong. It might even be up as high as 7%. I'd have to look at the census tables to tell you right now. But that number is a little bit more reflective of percent population than the African American versus Caucasian percents that you saw in the previous graph. We are now really only going to show you this graph for our MSU cases, unless there's a reason for us to go back to doing more data related to MSU cases. We did peak out that week of September 7th. We did see 72 cases beginning the week of November 2nd, which was back up again from what we had seen in the prior 3 to 4 weeks. And of course, this week just started. So those 4 cases are in there right now from the beginning of this week. And that is where we are today. Questions?
Go ahead, Ben.
Hi, Linda. I bet you probably thought of getting this particular question. What's your reaction on the findings of the Pfizer vaccine and the Biden-Harris response plan? And also, do you have a plan? Is the health department working on a plan to distribute that vaccine?
So my reaction is that the information that we heard about the Pfizer vaccine is very promising. They were not part of the Warp Speed project. So they paced themselves in a little bit different way. It still was very fast. So, we're expediting things through clinical trials. They're about to go into phase 3 clinical trials. Some of you know that I actually used to work for Pfizer, not for very long, because I was there when they were Pharmacia, and before that, the Upjohn company. And so I'm very familiar with the whole drug development process. So, we want to be cautious in not getting through clinical trials so fast that we're not confident in the safety of the vaccine. The efficacy numbers look great. And my place where I stand as far as knowing what's happened at the federal government and, getting vaccine out rapidly is that, there are people like Dr. Fauci, Dr. Murthy, who's just been named as one of the co-chairs of the task force under the Biden administration, and some of those other folks. Those are people that I've either worked with, heard speak at conferences for years, and have, the ultimate faith in what they will tell us. Because, I'm not part of looking at clinical trial, reports, documents after documents. So I can't tell you, how much confidence I have in that. What I can do is tell you that I know that there are people at that level that I have faith in, that they will tell us whether or not that vaccine is ready and safe to be deployed, or whether it's come out too fast and we need to be more cautious. And I would expect that to happen. But I believe it's all very promising. It's hopeful that that vaccine will come out. I don't think that we anticipated that we would have anything like 90% of efficacy, which is fantastic, because usually for a flu vaccine, if we get above 50%, we're doing great. So that's a really good sign in terms of efficacy of the vaccine. And that is after 2 doses. I think the doses are supposed to be about 21 days apart. As far as the Biden response plan, I'm really happy to see him put together a task force of medical and scientific experts who will be leading a response to coronavirus, the prioritization of a response to coronavirus at the federal level that hopefully will guide us in a more cohesive way across this country. That is not to say that we at the local level have not been doing a really good job. What it is to say is it's been left up for us to figure out and to do on our own. And in many, many cases, we've done a great job doing that, absent, better guidance or better, tools or better information or anything at other levels. We do have expertise at the local level as well. And we do have the capacity to figure out, what to do and what are the best actions to take. The third of your questions after that was what? What was number 3? Those were 2.
Number 3 was, I'm sorry, does the health department have a plan to distribute it once it's ready?
Yes, that has been part of planning. When I started working in public health was 2000, it was almost 20 years ago. My first job in public health was to be the emergency preparedness coordinator. In other words, write the plan for responding to a pandemic, responding to a massive disease outbreak that might have been intentional, like bioterrorism, how to mass vaccinate our entire population in 3 days, those sorts of things. So those plans have been in place. Health departments have been prepared to deploy in that way for many years. A lot of that planning takes place in a way where we have partners in the system, like the healthcare system will take care of vaccinating their own. They usually are responsible for vaccinating EMS and first responders. Then we vaccinate public health workers as well as the community at large. There will also be a prioritization early on as this vaccine comes out to go into the vulnerable areas, so particularly long-term care facilities and things like that, and make sure that those places where we're seeing this highest level of severe illness and death are places where we need to get to first with the vaccine. Then we're going to have to get out to other congregate settings and settings where we tend to have outbreaks and things like that. So you'll see somewhat of a tiered approach. I remember talking to somebody yesterday who said, well, so it's going to be quite a while before it gets to the general public. Not necessarily. When you know that health departments 20 years ago, sorry, that's the 6-year-old, started planning to basically be able to mass vaccinate our entire population, which is within 3 days, which was optimistic, I will tell you, to be able to do it in 3 days. But we had plans to be able to do it in 3 days. Whether that was going to work out or not, I don't know. But what I can tell you is that once we have enough vaccine, it's not going to take a long period of time to get that down from those priority groups and out to the general population.
Thank you. Go ahead, Scott Pohl.
Hi, Linda. I've got a couple of unrelated questions. Can I go ahead and just ask them both? Is that okay?
Okay. As long as I can remember them both. I forgot Ben's third, triple barreled.
I understand. That's why I asked. Your reaction to Tom Izzo's diagnosis, he's been very prominent about wearing masks, making PSAs, says he has done everything right, doesn't know how he got it, just your general reaction. And secondly, my observation that lines to get tested seem to be incredibly long. I've seen people talking about the line at the Sears location waiting 3 and 4 hours. Is that, other than the obvious, what might that be?
Okay, so on the Izzo thing, that is just one of those, while we do know that wearing the mask and taking all those precautions and doing all those things minimizes risk and can make it very low risk for you to get, we're not perfect. We are not perfect human beings. And as much as we think we always have that mask on or always wash our hands or always do the right thing, it can be that one time. All it takes is that one time. So statistically, we still mitigate to a large degree our risk of contracting this virus by doing those things. Do we eliminate it completely? No, we don't. And does somebody who is really diligent about doing all those right things sometimes get the virus? Yes. Keep in mind, you're talking about somebody who, I don't know about you, but I'm home a lot. I don't have to go coach a basketball team. I don't, there's a lot that goes on just in the context of basically living the life of Tom Izzo that is even taking all of those safety precautions is a little different than maybe some of us. He's working with a large number of youngsters. Some of them are always doing the right things and some of them aren't. Sometimes, I know I've been on calls or whatever with somebody and they've had a mask on. It's like, I can't understand what you're saying. I'm sure there are times he's dropped that mask. Keep in mind, his mask protects others from him. He also needs to be making sure always that others are wearing a mask around him. And what I see with athletes is the coaches and the trainers and all of the other people out there are wearing masks, but the athletes themselves are not. And I understand that, the football players are not wearing masks. Some of them are wearing shields. I think as we get into basketball, I don't think you'll see basketball players wearing masks. You don't see it at the professional level. And so you need to remember that. Tom Izzo's wearing his mask, but he's got a lot of basketball players around him that aren't necessarily wearing theirs all the time. And we've all seen Coach Izzo grab somebody and have a nice conversation with them. So, but again, that's not to say he did the wrong thing at all. It's the nature of his job. And it's also the nature of the way he does his job, and is also why he's so successful at doing his job. And, we all do the best we can. And he now has COVID. And as far as I know, all of that is going quite well. I haven't heard anything in terms of anything negative coming out of there. In terms of lines for testing, they are getting long. And we're going to have to try to start communicating, and hopefully you all can help us, about people and their sense of urgency about going and getting tested. I think I might have been exposed to somebody, so I'm going to go get tested. I was exposed to someone to go get tested tomorrow. It's like, one, if I was exposed to somebody today, I'm not going to get tested for a week, at least, because the bottom line is my body has got to incubate that virus if I'm going to get it before I'm going to test positive. Now, I also can go get that test and it's going to be negative, perhaps, and I'm still going to have to quarantine for 14 days. So taking the test doesn't get me out of quarantine. And if I don't have symptoms, there really might not be a reason for me to get that test, except I think I need to know. Well, you will know when you get symptoms, and it doesn't change the trajectory. Getting the test and knowing that you have COVID doesn't change the fact that you're going to have symptoms of COVID and whatever they're going to be. Nothing about getting a test changes the trajectory of what the illness is. The other thing we're seeing a lot of, and this is going to increase as we go into the holidays, is people who think that I'm going to go visit my family for the weekend, or I've got a group of friends and we all want to go up to a cottage up north, but we've all made a pact that we will get tested before we go. So you see people deciding that the way to go to social gatherings instead of not going to social gatherings is to test first and then feel like it's safe for them to go to social gatherings because they've done that testing or they've done that traveling. We've got to get people to stop doing that. What we have to get people to do is recognize that gatherings need to be done safely, or perhaps minimize them, or, keep it to 2 households, or keep it, small. Gatherings are not safe. Getting tested in order to go to a gathering, when I get tested today, first of all, at this point in time, I'm not going to have a result for 3 or 4 days. If I result for 4 days from now and I go to some gathering the next day, there is no guarantee that I'm still negative. So why did we all do that? Why did we all decide we're going to go to a social gathering in the way that we're going to determine that we can all be safe to gather together socially is that we get tested first so that we all know we're all safe? Well, we don't, because the very next day you could be positive. So that's one of the things that I'm hearing from Sparrow Health System. They hear a lot. People come through and it's like, oh, I'm getting tested because I'm going to go to this gathering. I am getting tested because I'm going to go travel to visit this family or these friends here. I'm going to go to this party, this wedding, this whatever, and they're going to get tested first. And everybody is getting tested first. And it's going to tax our system greatly if people keep approaching life in the way that it's like, I'm going to get tested before I do things so that I know that I and everybody around me is safe, because it's just not factual. And so we're creating long lines, we're taxing our capacity, we're utilizing resources in inappropriate ways when we're doing that. So if you could all kind of start to get out that message that, one, it doesn't work, and two, it is creating a great demand on our system at a time that we certainly don't need to be seeing that demand in our system. We're looking at turnaround times at Sparrow now, which used to be maybe 4 or 5 hours, 4 or 5 days, right? So now it's like, if you got symptoms and went and got tested, you just got to go isolate, because you're not even going to know you have a positive result for days, perhaps. So, we're kind of back in that place where testing results are coming sometimes at such lengthy periods of time after the test itself was done that it minimizes our ability to have any impact on the precautionary measures that need to be taken around it. That was a long answer.
Kate Wells, go ahead, please.
Yeah, thanks, Linda. Linda, my question is one that we've been asking a lot of folks right now in the county and local level. We are seeing this surge, I don't have to tell you, in cases and hospitalizations and deaths. It doesn't seem like in the immediate future there is a plan that both the legislature and the governor can both agree on. We heard the incoming legislative leaders say that they weren't going to do a mask mandate on top of the MDHHS mask mandate. One question that we're getting a lot from listeners is, why is there no lockdown this time? And I think my question for you is, do you have the tools that you need to fight this virus spread right now without a lockdown? And if the answer is no, do you think there would be even compliance with a second lockdown?
Well, one of the things that we have to take into consideration is that we look at numbers right now through the lens of what we knew in April still, right? So we're comparing them to numbers in April and saying, oh, in April, we need to look at this virus. We're in a different context related to case numbers, hospitalizations, much less acuity, much fewer severe illnesses. Though the death rates are up somewhat, the death rate overall is down. And we are, we continue to see the deaths. The mask order is in place statewide, whether the legislature decides on a mandate or not. There's an MDHHS order that requires it. And we do see fairly good compliance in this state, and certainly in this county, we see pretty good compliances with masks. All of those things are helpful. What's important to note right now is that we have widespread community transmission. You can't isolate and quarantine your way out of that. It just is. You isolate and quarantine and test and all of that sort of stuff your way out of clusters and outbreaks. That's an effective public health strategy. Public health strategy of identifying and investigating and contact tracing and isolating and quarantine doesn't work for widespread community transmission. What works is people doing the right thing, just like we say during flu season, which is also a widespread community transmission illness, right? It becomes widespread across the community. There's not really good ways to control it other than telling people, wash your hands, cover your cough, stay home when you're sick, and of course, get a vaccine. So that's kind of where we are with this right now, is this widespread community transmission that is in a context of a much less acuity when it comes to basically illnesses. So our hospitals are dealing with stresses and strains in different ways. The intensive labor that it takes for patients that aren't as severely ill that need to be proned and that sort of stuff. And then you're looking at taxing the public health system. So, we are going to have to, kind of strategize really more around outbreaks and clusters and high risk areas with our contact tracing and case investigation. Because as I said, when you have widespread community transmission, trying to call everybody and get them isolated and get all their contacts contacted and getting them quarantined just simply doesn't work with widespread community transmission. That is a public health tool for a different kind of, context. So, I think we have to keep just, measuring our way through this and looking once again, what's going on with our hospitals? What do we need to do about hospital capacity? What do public health departments need to do to help the community basically continue with, isolation and quarantine, but a little bit more self-guided. We give you that information every flu season. When you get the flu, here are the things you need to do. Cover your cough, stay home when you're sick, take those things. You should be isolating with the flu as well. So we're going to have to get that information out and help just really pump up the confidence and the education in the community around, you just tested positive. Now you know what to do. We're going to give you this information and we're going to let you figure this out. We're going to let you notify people who you're in close contact with, or, those sorts of things. So I see health departments all around me already starting to do that. So, and it's not for me, and I've seen some of my colleague health departments, and you've probably read some of them, their press releases that say, we just have way too many cases. We're overwhelmed. We can't keep up anymore. And so we're going to shift to prioritizing our contact tracing in these groups. I have a bit of a different message. My message isn't that we are overwhelmed and we can't anymore. I mean, we could hire more, we could keep going, but honestly, the effectiveness of doing that for widespread community transmission just doesn't exist. And it's a futile effort. We need to focus on younger people, older people, younger people mostly because they're in schools and daycares, older people, they're most at risk, vulnerable populations, congregate settings, true outbreaks and clusters, those sorts of things. We need to focus our efforts there, and we need people to start taking ownership of their illness and understanding what they need to do regarding isolation and quarantine to help contain the rest of what's going on with regard to community transmission to the extent that it can be contained. We never like to make that flu comparison because that gets criticized a lot, but we never in our wildest dreams think at the peak of flu season that we can get a hold of every single person with the flu, get them isolated, find out who their contacts are, get them quarantined, and that's going to end flu season. Because there are just far too many cases out there, and they're everywhere. They're not in any particular risk group. They're not in any particular setting. We get reports from employers, because the MIOSHA rule still is you must report a case, to the health, you must report the case. I mean, it's employers across the board, it's just, again, it's everywhere, it's like, and that's when you just really have to say, okay, this is the context of what we're dealing with right now. This is what we need from the public and for people. And when you get a confirmatory, a positive test, and this is what we will do as a health department to control the situations in vulnerable communities, outbreak settings, in those, specific age groups, those sorts of things, and then pay really, really close attention to what's going on in our hospitals and just keep your eye on that ball and make sure that we are ready to, shift or make further restrictions or things like that as we see those kinds of things start to happen. Again, with widespread community transmission, I don't even know how what strategy do you use to bring down those hospitalization rates?
I mean, what we used, and I guess what I hear you saying is, not to oversimplify, no, we're not at a stage right now where you feel like we need another lockdown to be ordered. Put aside the question of whether or not people would comply with it. Is there a state at which the hospitalizations would get to in which you would feel like it was necessary?
Yeah, that's a really good question. And we're having those questions a lot about schools too. It's like, should we close schools and go all virtual and no face-to-face? My colleagues across the state who have more schools that are face-to-face, we don't have very many in Ingham County, are basically keep saying, well, we're really not seeing an issue in our schools. So if the goal is to stop community transmission, is closing schools actually going to have any impact on that? So you've got to ask the same question about a shutdown or a shelter in place. What impact is it going to have? Because again, people are still going to go to grocery stores. People are still going to pick up food. People are still going to go to Home Depot and Lowe's. I mean, all of that stuff that was open. And remember, all of those essential workers that were out there are all still going to be out there in this broad scale community transmission, and they're going to be bringing it home. So does it even work is the question.
not to keep monopolizing it, wouldn't the argument be though that in the spring that did work, that was how we sort of got to that low case threshold?
Well, yeah, it did. But again, we didn't have as widespread community transmission as we do now. Look at that graph we had back in April. Look at where we are now. Yes, we have more cases and we have more hospitalizations, but we have this just widespread community transmission. We got to a point in April where we were kind of widespread community transmission. And I was feeling like there was a point where it was like, we know where these cases are. And then it was like, oh, they're just everywhere. But we were kind of coming out of lockdown, at that point in time. So it's, unfortunately, I don't have a perfect answer to that. What I have is a lot of ability to think through the pros and cons and the science on both sides of things. I mean, there's science on both sides of, is it actually safer for kids to be in school rather than to be virtual, because of the environment that they're in most of the day and all of the measures that are being taken and things like that. And those are the kinds of questions and some of the science that's out there about being at. And so you could apply that at a community level too and say, well, what's really going to be effective now? Yes, it was then, but again, we were in a bit of a different environment or context with regard to the virus at the time.
Thanks, Linda.
Mm-hmm.
Rachel Sweet, go ahead, please.
Hello. So I know you mentioned that other health departments were talking about being overwhelmed a little bit. So I've heard that contact tracing is said to be behind throughout the state. Do you know why that is? What can people do to help, volunteer, or do you know if more jobs will open up?
So what we need to do is to start to do public health the way public health is done. And that is when we have widespread transmission of an illness, flu season, norovirus season, whatever, what we do is we focus on outbreaks, vulnerable populations. We do the case investigation and the contact tracing there. And what the public needs to do is go, oh, I just got a confirmed test. I'm COVID positive. I now will isolate for 10 days or until 24 hours after my fever is over. And I know what a close contact is because the health department helped me understand that definition. And I will notify those people that are my close contacts so that they know what to do too. There's a lot of this that we are doing that is very basic that some people, that people can kind of handle on their own. So that's kind of where we're heading. It's like you could add more contact tracing, but again, at what point is that effective with widespread community transmission rather than asking people to take that, positive test and then do the right thing with it. The bottom line is I can call them on the phone and tell them to do the right thing and they may or may not do it, just about probably the same as they get that positive result themselves and may or may not actually isolate or stay home. The compliance with it is not perfect. It never has been. Again, we are taxing our system. We have lots and lots of cases. Here in Ingham County, we can have as many as 150 or 200 in a day. Now, then you have to call all those people. Again, you're not getting results until 4 days. Sometimes that result is not getting into the system so that we're notified about it for another day or two. So we're now 6 days into somebody's illness, or when they tested anyway, they may have had symptoms a day or two before, and they could be managing them themselves instead of waiting for us to call, and we're calling after the fact. So we just kind of need to shift our strategy. And to me, like I said, I've seen my colleagues, and yes, we're overwhelmed. We've done quite well here. I mean, we got ourselves through that MSU outbreak where we were dealing with that kind of number of cases a day, and we kept marching through, but it was intense and it was a lot. It's a fairly intense pace to keep up with. And so you start to ask yourself, is that really the right way to go about public health right now? Or is the right way to go about public health to do the contact tracing and all of that sort of stuff around the areas that we know are most important to do it, and to start really educating the public and turning over the responsibility of knowing when you have a positive test result, what you need to do to the people themselves, because they're going to have that information long before we are.
Okay. And then also, I don't know if you heard, the Michigan Department of Labor was given $3.33 million in grants from the U.S. Department. And they're going to give 30% of that money is going to go to help with contact tracing. Do you know, or have you heard if any of that money will be helping here in mid-Michigan?
I have not. The state has a number of contact tracers that help with counties all across the state. I don't know if they're going to use that money to build up that. I mean, honestly, even dealing with outbreaks and clusters, outbreaks in long-term care facilities, what's going on around deaths, helping employers through situations, even all of that is still a lot of work, absent contacting every single person with a positive test. And so there's still, those resources will be helpful even at basically, it's like, what is the proper public health strategy for going about containing a virus when you're dealing with a virus that is really widespread in the community? You contain the clusters, you contain the congregate settings, you contain in the vulnerable populations, you protect the vulnerable populations. That's the way we go about that work.
Okay, and then last question, would you say that we're in a second wave now, or what would you say?
Absolutely. Yeah, and I think the evidence for that basically is, I mean, first of all, we all know that we really poorly controlled the first wave. By the time the MSU related cases, peaked out, I wasn't sure if it was a second wave or just another fairly significant outbreak in a poorly controlled first wave. We came down from that nicely and then just started going up. And that happened at the same time as you started to hear nationwide cases are surging, statewide cases are surging, in Europe cases are surging. When you hear that everywhere, that's a second wave. When you see it in clusters, it's like, oh, they're having problems in Wisconsin now, but they got that under control. Remember, we used to see the maps and it's like, oh, Michigan is green right now, or Michigan is yellow, but this state over here is red. And there were times when it was like there was 1 or 2 states that were red, but everybody else was keeping it in control. Now everything's red and everybody's struggling and cases are surging everywhere. Every state, all across this country and across most of Europe and many other countries as well. So that tells me that it's not just, okay, we're having, little breakouts from the first wave and things are getting out of control in certain places, because it's broad scale, which pretty much tells you it's a second wave.
Thank you very much.
Mm-hmm.
Does anyone else have a question? Ben, go ahead.
Hello again, Linda. A couple weeks ago, I asked you about there was a Trump rally and there were a lot of the crowd was not wearing masks. This past weekend, in response to the projected win from the Biden-Harris ticket, there were also a lot of crowds, and I believe there was even one in Lansing. I did not see a lot of social distancing, but I did see a lot of masks. And I'm seeing a lot of people on social media like saying, why aren't we as worried about this as we were on certain other things? So what's your reaction to that? Are you seeing the same stuff? Like the same?
I saw the same thing. I mean, when people went out, when the announcement came out on Saturday, that Biden was the projected winner, when they called Pennsylvania, and people in the streets in Washington, I did see a lot of mask wearing. Again, we're outdoors, which is somewhat safer than indoors, not completely safe. Some of those rallies happened indoors and without masks. Again, it's really hard. I mean, we start to try to find places where it's like, oh, these people did this, that's going to cause a problem. And it's really hard to see that in the midst of just such broad community transmission. So I think we just need to start focusing on the fact that we have this virus across our community everywhere. Assume it's there everywhere you go, and less focus on, there's a place that's dangerous or these people did dangerous things. That's happening. We need people to wear masks. We need people to social distance. We need people to avoid these gatherings, and we can keep that community-wide transmission lower. So, that's where our success is right now. Absent a vaccine and absent a cure is in really strict adherence to those things. Dr. Fauci has been saying that for months, that if we can get strict adherence to mask wearing and social distancing and gathering restrictions and those sorts of things, we can get through this second wave without significant disruption. So we need to keep doing that. Now, significant disruption means shutdowns and things like that again. It doesn't mean there's a significant disruption because we have far more cases than we did in April. Again, we need to look at that context and realize that we're really in a different space with this virus right now than we were then.
Also,
So, yes,
oh, were you going to say something else? I'm sorry.
I don't remember.
I also heard Dr. Caldoun last week in the state's briefing say that there are some people who they've contacted about the virus and they don't know how they got it. Has that happened to your knowledge in Ingham County where people get the virus and they try to contact trace, but those people don't know how they've gotten it?
Okay, so first of all, the contact tracing is when you get a hold of a case, they tell you who their contacts are, right? So we're not going backwards. Now, it is very, very common for people to say, I have no idea where I got it. You know, we were just talking about Coach Izzo, no clue. So that's not uncommon. And I actually just did read an article not long ago. I think it might've been in the Atlantic. I can't remember, where it's like, we should be doing contact tracing backwards to find out where that person got infected rather than contact tracing going forward. Because what we know is that this virus also has, remember we were talking about R0 early on with this virus. So every person that is infected will infect a certain number of other people. Well, as it turns out, some people infect more people than others. There's a scientific thought out there that about 80% of cases are caused by about 10 or 20%. So there are a small number of people who tend to have the ability to infect lots of people, whereas other people don't infect very many. And so that K factor also kind of, that's what it's called, K factor, kind of explains why we see these clusters and some ability to kind of regionally or locally control things when we're able to contain those kind of super spreader people or super spreader events. So if you were to go backwards and be able to say, okay, this person back here was identified by 5 people, and it's like, okay, this might be a super spreader kind of person. So it was kind of just an interesting concept in terms of going backwards with contact tracing instead of going forwards. But, if I find that article, I'll send it to you. I'll send it to Amanda or something like that and get it out to you guys. But I was just reading it the other day and it's like, oh, that's kind of interesting. And I have been observing this kind of rather uniqueness with this virus. Again, not to compare it to flu. When flu is out there, it's just everywhere. This, it's like, why would Ingham County have numbers that are a third, half, whatever, several other counties that are around us? Why can things go better in a certain geography than other places? Because that's just not typical of a respiratory virus. And that K factor kind of explains that. You get people or events that basically infect lots of people, and then that becomes the issue.